All right, let's talk about the upper limb myotomes, dermatomes, and cutaneous fields. And as we do, we're going to answer a few questions like, what is a myotome, dermatome, and cutaneous field? How are cutaneous fields different than dermatomes? How are these three types of innervation distributed in the upper limb? And what is the clinical significance of all of these? And that's where we're going to start today, is with the clinical significance. So we have this scenario here of a 54-year-old male who presents to the clinic with upper limb deficits following a fall from a ladder. He complains he's unable to spread his fingers. Additionally, physical examination reveals hypoesthesia from the skin overlying the medial epicondyle. What nervous structure is most likely injured? So we're going to go through some of my initial thoughts here. So on this, we've got the symptom of unable to spread his fingers. That probably means weak abduction of the digits. We know the dorsal interossei muscles do abduction because the DAB, dorsal do AB, and those are innervated by the ulnar nerve. And then the other symptom we're seeing is hypoesthesia over the medial epicondyle. That just means numbness in that area. So I know when we learned to draw the brachial plexus, we heard of the medial brachial cutaneous nerve and the antebrachial cutaneous. Maybe it's one of those, but we're going to see today. So remember this scenario as we're going through this video, and we're going to come back to it at the end. Moving on from the scenario, we're going to talk about myotomes. A myotome is a group of muscles innervated by a single spinal nerve level. So some of the levels we're seeing here is C5, C6, C7, all the way to T1. So if one of these was injured, say the C6 ventral ramus here, this root of the brachial plexus, that's going to affect a certain amount of muscles that are receiving those somatic motor neurons that run through that ventral ramus. So the symptoms here would be different than, say, an injury to the musculocutaneous nerve. One other place you might have seen the word myotome is in embryology, so I wanted to clarify the definitions. In embryology, a myotome is a portion of a somite from which skeletal muscles are derived, and we can see that myotome there. So you can see these terms are related because they're talking about muscles that are innervated or muscles that are derived, but separate, so I wanted to make that clear. So our next question is, what are the myotomes of the upper limb? So we kind of flipped our brachial plexus. We have a left brachial plexus. We have this chart with myotomes. This chart is a little bit simplified because I think it's easier to remember this way. But with C5, we'll maybe start with this. It does shoulder abduction. And there's some other movements here that we could have added that have to do with the shoulder, but shoulder abduction is a big one with C5. C6, doing elbow flexion. C7, elbow extension, and we could have added things like wrist extension as well, but a lot of extension with C7. C8 is doing finger flexion, and then T1 is finger abduction, and we could have added adduction as well. So say the C8 myotome, if we had a lesion here, then we're going to have difficulty with flexing the digits. And that is it for myotomes, so let's move to dermatomes now. So a dermatome is an area of skin innervated by a single spinal nerve level. So again, we've got these spinal nerve levels here. We've got C5 ventral ramus, C6 ventral ramus, and these are each carrying sensory information from the upper limb. So an injury to the C5 ventral ramus here, this root of the brachial plexus, will have different symptoms than, say, a musculocutaneous nerve would with sensory. And just like the myotomes, dermatomes are also seen in embryology. So in embryology, it is a portion of a somite from which the dermis of the back is derived. So in this video, we're talking about the clinical definition of an area of skin innervated by a single spinal nerve level. Here is a table with the upper limb dermatomes. You can see C5 is carrying information from the lateral shoulder, so it's doing sensation there. C6 does sensation of the thumb. C7 is doing the middle finger, and one way you can remember that is C7, no heaven, I guess if you're flipping people off all the time. C8 is doing the fifth digit, and then T1 does the medial epicondyle. And so to see that now on an image, we've got C5, lateral shoulder, C6 on the thumb, C7 on the middle finger, C8, digit 5, and then T1, the medial epicondyle. One note on dermatomes is that they are not exactly consistent across different resources. So you can see this Moore's dermatomal map is different than the complete anatomy map. Like for example, complete anatomy has C5 going almost all the way to the wrist, where in Moore's, it doesn't get any of the forearm at all. And so what we end up using are some specific locations for clinical testing where most resources agree. So example, C5, the lateral shoulder, pretty consistent right there. C6 with the thumb, C7 middle finger, C8 digit 5, and then T1 the medial epicondyle. So those were the locations I put in that table that we showed before. And then the last thing we're going to talk about are cutaneous fields. So cutaneous fields are areas of skin innervated by a single peripheral nerve branch. So instead of being innervated by like the C5 spinal nerve or the C5 ventral ramus, we're saying it's innervated by the musculocutaneous nerve, which receives contribution from C5, but as well as C6 and C7. So we'll see that cutaneous fields are going to have a different distribution than the dermatomal maps that we just saw. Now let's look at the maps of the upper limb cutaneous fields and see how these may differ from the dermatomal maps we just looked at. So here we've got an anterior view of the right upper limb, and you can see we have some of these colored in. So the first one we'll do is from the axillary nerve. It's doing the lateral shoulder and this specific branch of the axillary nerve. It's called the superior lateral brachial cutaneous nerve. So lateral shoulder there. And then as we move down, if we have a superior lateral brachiocutaneous, we probably have an inferior lateral brachiocutaneous, and that is a branch of the radial nerve. And then when we move over medially, we have a medial brachiocutaneous. And then this guy in pink, it's not a part of the brachial plexus, but it's here on the upper limb. It's an intercostobrachial nerve that's doing that area. And now let's look at these all again on a posterior view of the upper limb. So again, we're seeing this branch of axillary doing the lateral shoulder. We're still seeing from radial the inferior lateral brachial cutaneous, and then we're seeing the medial brachial cutaneous as well, and intercostal brachial. The one that we're adding is another branch of the radial nerve and is the dorsal brachial cutaneous. And that makes sense because we know the radial nerve is basically doing all the muscles that are posterior, so we're going to see the radial nerve doing a lot of the sensory posterior as well. Moving distally, we'll now do the cutaneous fields of the forearm and hand. So we can see here we've got a little branch of radial popping out here, and we'll maybe talk about this one a little bit more when we do the posterior. But then from musculocutaneous, we have a branch called the lateral antebrachial cutaneous nerve right there doing the lateral forearm. And then we also have a medial antebrachial cutaneous nerve right here. And then when we move to the hand, we know the median and ulnar nerve are doing most of the innervation of the hand for the muscle, so it makes sense they're doing a lot of the sensory, with the ulnar on the ulnar half doing the 5th digit and the ulnar half of the 4th digit. And then the median nerve doing the majority of the thumb, the 2nd, 3rd, and then half of the 4th digit. And then we get a little bit of another branch of radial nerve kind of peeking out anteriorly here. Looking at the posterior view now of the right upper limb, we see we still have the medial antebrachial cutaneous nerve. We still have the lateral antebrachial cutaneous nerve from musculocutaneous here, but then we have a good sized branch from the radial. So this is the dorsal antebrachial cutaneous nerve from radial. Again, makes sense because radial is doing everything posterior, and that was the one that we were seeing kind of peeking through over here. And then on the posterior aspect of the hand, we still see ulnar on the 5th and part of the 4th digit, but then we're seeing this superficial branch of the radial nerve doing a good amount of the thumb through about half of the 4th digit, but then the median nerve is kind of getting the most distal portions of those digits still in the purple. And that is it for the cutaneous fields. Here's an image with all of the fields so you can have them for your notes. So now to finish, let's come back to our clinical scenario here. So again, we had this patient unable to abduct his digits, as well as having numbness over the medial epicondyle. Initial thoughts, maybe the ulnar nerve, maybe one of the medial brachial or antebrachial cutaneous nerves. But now let's see what we could figure out with the myotomes and the dermatomes. So weak abduction of the digits, that is the T1 myotome that's responsible for digit abduction via those dorsal interossei muscles. And then for the hyposthesia over the medial epicondyle, that's also the T1 dermatome that's responsible for sensory innervation of the skin that overlies the medial epicondyle. So most likely, it seems like it's a little bit more possible to have just the T1 spinal nerve be injured rather than, oh, we've injured the ulnar nerve plus one of these other nerves. So this is most likely a T1 spinal nerve issue that this patient is experiencing. And that is what makes it so useful to be aware and to know dermatomes, cutaneous fields, and myotomes, because that can help you differentiate a peripheral nerve injury from a spinal nerve injury. And that is it. So let's do a quick review. So we learned the C5 spinal nerve level is responsible for shoulder abduction and does sensation of the lateral shoulder. C6 does elbow flexion and sensation of the thumb. C7, elbow extension and does the middle finger, the entirety of it. C8 does finger flexion and sensation of the 5th digit. And then T1 that we just saw in our little clinical scenario does finger abduction and then sensation of the medial epicondyle. And that is it for our video on the upper limb myotomes, dermatomes, and cutaneous fields.